Racism is intertwined in all our country's key systems: healthcare, education, criminal justice, agriculture, and beyond. Many systems struggle to build trust with historically oppressed communities. The refrain repeats, how do we get communities to trust us? But what if instead we asked, how do we create a system that is worthy of trust? Using the healthcare system as an exemplar, with special attention to the irrefutable display of inequity during COVID-19, panelists will explore this question from our varied areas of expertise in health leadership, education, research, clinical care, and community engagement. Attendees will leave empowered to transform their own system, whatever their field, through developing critical consciousness, creating accountability, challenging the status quo, and embodying a spirit of humility, respect, and willingness to listen. The use of storytelling and an action-oriented approach will provide ideas and tools for all within and outside of healthcare. Here to provide moderation and to introduce the panel, Dr. Vivek Balasubramaniam, a pediatric pulmonologist, member of the Department of Pediatrics Anti-Racism Task Force Education Committee, past chair of the Society for Pediatric Research Advocacy Committee, and member of the American Academy of Pediatrics Section on Minority Health, Equity, and Inclusion. Doctor.
Thank you. Welcome. Thanks for this opportunity to come speak with you guys. We want to try to make this as informal as possible. What we'd love is for questions to come in about the topics that we're going to talk about on the chat, and for all of you who are in attendance here in person, which is a great thing, if you feel, please use the blue cards that are on your table to write your questions and hold them up, and somebody will pick them up and bring them to us. So I want to start by letting our panelists introduce ourselves and introduce two of our panel members who couldn't be here today. I'm going to start with the two that couldn't be here today. The first is Shiva Birarshilef. She's the UW Health Vice President and Chief Diversity Officer, and she leads the overall mission, vision, coordination, and strategy for UW Health's DEI initiatives. She served as the City of Madison Alder from 2009 to 2011, or 2021, sorry, and holds leadership positions with many community organizations. Another person that was critical in the development of this is Yolanda Evans. Dr. Evans is the Clinical Director of Adolescent Medicine at Seattle Children's Hospital. She has extensive research expertise in digital technology communication. And I'll turn it over to our other panelists to introduce themselves.
Hi, I'm Emily Riedinger. I am an adolescent medicine specialist in the Department of Pediatrics at UW-Madison, and also one of the associate program directors for our pediatric residency program with a strong finger in the pot of education, medical education.
Hi, my name is Brianna Roberts. I'm a medical assistant at 20 South Park Pediatrics.
And good afternoon. I'm Dr. Cheryl Henderson. I'm a pediatric infectious disease specialist here at the University of Wisconsin. And I am going to be setting the stage a little bit for our discussions this afternoon. Much of what I have been working with for the past several months, at least over a year, is really understanding the COVID vaccine and working with people to understand how effective it is, how safe it is, and how we can really end this pandemic. But really to start on, just in general, as you know, we're all here with healthcare, and although this is going to be a focus from healthcare, hopefully the concepts that we're discussing can really go across disciplines, different fields, as well as the fact that, you know, racism is a topic that is really hot and appropriately so on people's lips, and really central to a lot of what we're discussing here, but also recognize that there are inequities in many different areas, and again, hopefully some of the concepts that we're talking about can really translate over. I did want to start, though, by just making sure that as we're talking about race, because that's going to be the primary focus here, that we have appropriate definitions. And I have to say, I went to the Merriam-Webster dictionary, as thousands of people did, especially after the summer of last year with a lot of the racial injustice protests in March. And one thing I discovered there is that the definition in Merriam-Webster has been updated as of summer of 22, because there was one graduate student who looked at the definition and said, there's more to racism than this, and we really need to include systemic racism. So that we're all at the same level, I just wanted to point out a couple of things. The main thing is that, just as we recognize, race is a social construct. It's not biological, although many people believe that it might be. So even in the healthcare field, there's many people who, and there's studies on this, who believe that black people actually have a much higher threshold for pain, so less need for pain medicine, etc. So here's the definitions, just so we're there. So race is any one of the group that humans are often divided into based on physical traits regarded as common among people of shared ancestry. And as a social construct, this really came to be more in the 17th and 18th century when there was a lot of European colonization, and it was used to justify activities such as enslaving Africans or removing Native Americans from their ancestral lands, and it has just permeated a lot of the structures that we see today in the U.S. And then there's two parts now for racism that I will read, including the second one that is very new. First is a belief that race is a fundamental determinant of human traits and capacities, and that racial differences produce an inherent superiority of a particular race. And the second definition is of, relating to, or characterized by the systemic oppression of a racial group to the social, economic, and political advantage of another. So as we talk about racism and structural racism, we can keep these definitions in mind. Well, I don't have to tell anyone here or in the United States that a year and a half ago we were all struck by a virus that really disrupted our economy and so far has killed over 5 million people worldwide. And while we were all in the midst of locking down and doing what was needed, it became apparent that there were clear racial disparities in who was getting infected and who was being hospitalized and dying. And for many, that wasn't surprising, especially if we are of racial minorities overall. But early in the pandemic, Black, Hispanic, and Native Americans were as much as 2.5 to 3 times more likely to be hospitalized with COVID-19. And even now, most recently, they're still 2 to 2.5 more likely to be hospitalized or die of COVID-19. So these inequities exist in addition to many other healthcare inequities that have been here, but there's now more of a spotlight on. What are the reasons? Well, we know that, the Black and Hispanic families were more likely to be essential workers, live in multi-generational households. They also lack access to health care. And they're still currently confronting many implicit biases in health care. Well, 1 year ago to this month, the vaccine came out. And one might logically say, well, the people most effective are going to be the most ready to get a vaccine. And there's Kaiser Family Foundation does polls. There were a lot of surveys that came out, and one that really showed that if you looked at Black Americans, more than 50%, this is in October 2020, said, I'm definitely not getting a vaccine or I'm very unlikely to. And 35% of those said the reason is we just don't trust them. Any vaccine that the government's going to push, we just don't trust. And I know we hear it in many other places, but that was one of the largest numbers, largest cohorts. And so why is that? I mean, we will be talking, well, actually currently, as we know, there's a relatively slow uptake of vaccine, but if we even look at Wisconsin, Black Wisconsinites are still 30% less likely to be vaccinated than white Wisconsinites. So there's still disparities in vaccine uptake. So much of what we'll be discussing today is trust in healthcare. And that begs the question, why is there distrust in healthcare? And there are many reasons. And as we talk to primarily Black and African Americans, a lot of this distrust comes from a long history of medical experimentation. When I say long history, if you go back to the time when people were enslaved, they were considered property. Again, there was not necessarily a consideration of pain in terms of experiments. So one One person, if you've heard of Dr. J. Marion Sims, is the father of gynecology, and he's known as the father of gynecology. But much of his work in developing his procedures were done on enslaved women without anesthesia. And it wasn't until it was perfected that white women would get anesthesia, and then the procedures would continue. But that was, that's well known. But that was somewhat of a norm, where there were doctors, physicians, surgeons who would either purchase slaves or enslaved people as property for the purpose of medical experimentation. So with a long history, some of which is still very current, it's important to recognize that the distrust is well justified, and it's not something that will be switched off immediately. There's a lot of work to do. And I will leave it there because that is what we are here to discuss. Thank you.
So again, I encourage you to send us questions or think of questions here. What I want to start off with is just to ask this group a question. I'd like you to raise your hand if you've experienced or witnessed racism in the healthcare setting. Please show hands. So there are a few that have that. So we're hoping that as we talk and as you hear what we're going to discuss, that you'll think about this, and that may change, and you may recognize that you have been witness to it. I want to start out by talking about trust. So this is a term that is invoked when we talk about disrupting health inequalities that limit access and quality medical care for marginalized communities. But really, is there a difference between the concepts of building trust and becoming trustworthy? Like Brianne, can you please start with?
Yeah. An incident happened at my workplace where one of my coworkers called a patient a monkey. Now, the parents of this patient is black. The kid was black. A monkey in the black community is a derogatory word. The reason for this is because if y'all ever seen that ad H&M had posted, it was a kid and he wore a sweatshirt, and it was like, it said something like, it displayed a young black boy, and on his t-shirt it said, the coolest monkey in the jungle. And H&M had took that down. They apologized for that. When my coworker, she was a white coworker, she didn't understand why that monkey was a bad word for a black kid. I tried to explain to her that in the black community, monkey is a really bad word, and we don't like being called that. When that happened, she did apologize a lot, and like I tried to tell her, like, it's hard being black, and when you see someone make a mistake and they don't know the mistake that they made was something bad, and trying to tell them like the difference between talking, well, first just talking and not knowing what you're saying, like that was really bad in that situation. My apologies. I told her to try to think before she speak, and that we should take accountability of the things that we do in healthcare. A lot of times we talk about things that other people wouldn't understand because we all come from different cultures. We all come from different backgrounds. We all are raised differently. And I explained that because we are raised differently, different things we take differently. Words you can say wouldn't hurt someone else's feelings, but would really impact your day. Learning from the mistakes. That's the trust in the healthcare. The patient was really upset. It really hurt the parents' feelings because a monkey is a really bad word. They did not want to return back to our clinic, and then we had a whole thing about the words we speak to parents or the words we speak to children, because they are sponges and they do listen to everything that we say.
So as we think about that, the concept of trust and trustworthiness, there is if you think about it, when we say, how can we get somebody to trust us, we put the onus on them to trust us, that there's something wrong with them, something different about them that they can't trust us. As a healthcare provider, from what you heard, there are challenges that we have that are historical, that go far beyond our lifetime, our lifespan, that impact how people trust the healthcare system. So it is upon us to determine, can we become a trustworthy institution? Can we become trustworthy, and what is it that we need to do to be trustworthy? Cheryl, do you have thoughts?
Well, one thing you did mention overall is just some of the historical ramifications of, as I mentioned earlier, even just medical experimentation. And that one of the first things is just becoming aware that there has been throughout the history, and I'll focus on this country, differences, power differentials, there's structural racism overall. And that every one of us who's living today, we are who we are because of people who came before us. So each of us has learned some cultures, some approaches to life from our parents, from our grandparents. And so I guess the first part is becoming aware that what we're seeing now is the result of what has come many, many years ago. So when we talk about the roots, the historical roots of structural racism in this country, they really run deep. I gave one example. There's many, many more that we don't need to, or unless you want to, we don't need to go into. But the way I think about it is somebody in my generation has learned from my parent or my grandparent, and they in turn had learned from their parent or grandparent. So if we're talking about someone whose ancestors were enslaved, that's really only 2 or 3 generations ago when I talk about grandparent and then another grandparent. And so as we heard earlier, there's might be concepts, words that are used that are not really, that might be used in just casual conversation but have implications overall. So I'm saying a lot of this is to really say that, having forums like this, really being educated about how different cultures, different people from different races really view healthcare. And again, I guess it goes back to asking the questions that we did when we were talking about the COVID vaccine. Instead of just going in and saying they're safe, they're effective, get one. One has to really step back and say, what are your fears? What are your concerns? What are your questions? Let's have a conversation and really recognize where some of the concerns or fears come from.
So Emily, as a pediatrician who works in an office and is unfortunately probably a witness to many episodes that could be considered racism, what thoughts do you have on how to address that as thinking about as a bystander or as somebody who's involved in an interaction that goes along with that?
I think something that folks can be prone to do is watch an interaction, and if you're not a part of it as a bystander, be disinclined to insert themselves into an interaction. And a cultural shift that we need in medicine, and I think we need in many institutions, is for people to feel that personal responsibility to be part of the solution, to take that step, to be more active, to not watch things happen, but to really be a participant and kind of intervene. Something that struck me when Brianna was talking was that the onus was placed on her to educate her coworker who kind of made that comment. And I think that as a white identifying provider, the onus actually is on me. It's on me to learn and understand and accept that feedback if I do make an error. When I do make an error is probably a more accurate way to say it, with humility. And then go forward and do that learning myself and try, and understand, why is this comment hurtful or harmful if I don't know that coming in. I was also listening to our speakers and thinking about something that happens in medicine, and I think in many other fields, is our understanding of an issue or a challenge starts the moment that we enter the scene very often. And I think in healthcare, an example of that as a consultant or someone who often serves in a consulting capacity would be if a patient comes to me, they may have already seen 3 or 4 doctors, but it's as if my mental schema of their disease or illness begins the minute that I start seeing them, instead of recognizing that they may have already had a long history with this illness and a long workup and that sort of thing. And I think that's a common trap that we as physicians can fall into. And I think that almost that same thing kind of applies here when folks enter the situation saying like, well, but I didn't do that. I wasn't, John Marion Sims or whatever, and not recognize that that legacy persists, and that's part of that patient's story, and understanding that is really important to being part of the solution.
So often as an individual, we feel you can trust me. What you've experienced with others in the past is not the reason not to trust me. But an understanding of, I think, the historical oppression and the power structure that has been created is really important. And ignorance of this history is really one of the main problems that we face as a healthcare industry, and I think as any entity, to becoming trustworthy. And Cheryl, I'd like to, can you expand a little bit more on this?
So, yeah, I mentioned education, being aware is some of the first step, but as healthcare organizations, what are the actions that need to be done? And, I think we can look around and see what is being done in many healthcare organizations, including our own, is involving people of racial minority communities or at every level of decision making. As I was looking at this, I saw the term diversity lens, so that when policing is being made, to step back and say, does this really affect everybody? Or how does it affect different people? Is it still going to be a positive experience, or are we marginalizing a group overall? But I think really the other part is having input at levels of the administration, of leadership, of people who do come from different racial groups overall. But one has to really make that commitment. When we think about in education, there's been students who come in because their parents went to a school overall, and so that really just ends up perpetuating generations and generations, but of what may end up being more of it's not really mono, because none of us are all the same within a culture, but exclusionary to some extent. And so the same thing happens in healthcare and administration overall, that the further you go up, the less diversity there is. So it's a commitment to making sure that people, I'll say it, that they're people at the table. And I'll use the phrase that I heard somebody else say at a conference similar to this, is that, if you're inviting Black Americans or Hispanic Americans to the table, well, who is actually planning the menu and setting the table? Whose agenda is it? And, that can even go further to say, well, what's going to work better, a rectangular table or a circular table? There really has to be a partnership at building the table. Not just being invited to the table, but building the table in a way that's going to work for everyone. And that takes a lot of work, a lot of listening, and a lot of partnership.
So back, if I might, I have a comment from Yolanda, one of our panelists who couldn't be here today, was reflecting on the story shared by Brianna. And her comment was that, even when that coworker was unaware, there was an opportunity to pause and listen to the family, hear their concern and emotion, and validate that emotion. And listening without being defensive and actively owning mistakes is so important to that concept of becoming trustworthy. So that concept of listening, which I think kind of fits a little bit with what you were saying, Cheryl, of like who's deciding what the table even looks like. It's one thing to bring someone to the table, it's another to ask them, what should the table be? And really do that active listening.
So, Brianna, in your role, you're the face of the first interaction that many patients have with our healthcare system. In that light, how do you, what have you experienced, and how do you work with the thought of becoming trustworthy and reflecting that the organization you're working for is a trustworthy organization to these patients?
Yes. I was actually always taught growing up, trust is earned, not given. Many of us, we probably go to the doctor if we're pretty healthy once a year, and that's just for your routine checkup. If you go more than that, then maybe you have a better relationship with your provider, or you talk to your provider a little bit more, so y'all building that trust. With me personally in healthcare, as far as when I'm in there with patients, it's a lot of patients that will not open up to you, and that's okay because they don't know you. If they only come once a year, you can't expect for them to just be like, okay, yeah, I'm just going to tell you my whole life story. That's not what happens. Even if they do come back a few times, it takes time for them to open up. They have to see you for a few times for them to be comfortable enough to tell you anything. In healthcare, I feel like it's a lot of distrust because you can tell your provider one thing and it be misinterpreted in the Black community. We have been taught it's really aggressive when we speak. When we're angry, they feel like when we're angry and we speak, our voices might get a little louder, which means it's an aggressive talk. It's you're talking too loud, or why are you angry? And then that just causes us to shut down. It's hard sometimes when I'm a Black woman and I work in a facility and our Black people come in and they're angry. With the whole patient with the monkey situation, the parents were extremely angry. They did not want to talk. They were angry, they were screaming, and that's okay. They're right to feel the way they feel. But a lot of people didn't understand why they were reacting that way. But me being Black and living in the Black community, I understand. So I talk to them like a Black person. I understand why you're angry, and I understand why you're mad. I'll be outraged as well. However, we are taking steps to educate the person who said this. So it's all about learning from our mistakes, learning to know that not everyone grew up the same, not everybody have the same outlook on life, and being able to be open and learn from the things that we say and the things that we do.
So that just makes me think about kind of interactions that we have in healthcare. The one thing that I realized over the last year in particular, as we had to make a switch from seeing patients in person to seeing patients by video, is one thing I realized is that you get a look into somebody's personal life on a video screen that we did not have that window to when we were seeing them in person in our office. In our office, and it is on our terms, and our office is on our turf, that we were engaging with people, and we as in healthcare have to disarm people enough that they reflect and they share with us some of the most intimate details of how they carry on their lives and what is going on in their lives. And during that time, it is critical that we have time. And in this chaotic world we live in now, time is not given very much. And I've seen multiple times that I'll walk in about to go into a patient's room, and my nurse will tell me, oh, good luck, that person is going to be a little difficult. And I realize as I'm walking in the room that the only thing that will disarm that person, that will make them feel that they're in a trustworthy place, is if I sit and I listen. And that's the key, I think, is listening. So if you want to improve how trustworthy wherever you are is, wherever you're working or acting is taking the time to listen, and taking the time to listen and listen openly, and not feel like someone is attacking you or criticizing you. And I think those are the key things that we need to think about as you think about how you become trustworthy in going forward.
Can I add on to that? To expand a little bit, I agree absolutely as an individual provider, working with people living with HIV, sometimes I have to step back and say, well, when they go home, living with HIV is a tiny part of what they're thinking of. It's when they come here that it's 100% what we're talking about, and to recognize that. But what I wanted to expand on is, we've talked about this is a one-on-one, be humble overall, but how do we do this from an institutional level? And working with COVID-19 and with many other groups, one concept is using listening sessions and having a group of people come together, and for those representing the healthcare organization or the organization are really there to listen. Maybe ask a question, but not say a word. And just to really listen, understand if there is a question, what are the concerns, what are the fears, as I've said before, but also what are the strengths within that community? What are the talents? What are the skills? What works in terms of solving a problem? But sometimes it can be difficult to just listen. And that's why they're called listening sessions in that sense, is that there really is just listen, get information, don't talk, don't bring in the perspective of the structures that we're more familiar with, but find out what structures work within the culture or the community that is being listened to.
This conversation about time and kind of bringing it to the institutional level is making me think a little bit about some comments Shiva made when we were doing our planning sessions, and she's very sorry she couldn't be here today, but in her role in leadership, she was describing how we're talking about something that has been present for centuries, and often at the institutional level, people want to see outcomes 6 months, a year, and these really short little time frames. What can you measure that's going to tell me that you're making an impact? And that sometimes there is this loss of recognition that we do need time to do these things, to listen. And if a system is really going to be changed and dismantled, we're probably not going to measure that in a 2-month increment or a 6-month increment, and we need to be really thinking about some of those deeper changes, including, major culture shifts in an institution that was built by and for white people to make it more inclusive. And how do we get buy-in from everyone, including folks who want to see that outcome today, tomorrow, 6 months from now, for something that really has very deep roots?
And along those lines, when you talk about the institution, we think about that, how is an institution thinking? Is it thinking of their leaders? And leaders, like any individual, you're brought up with your own set of biases and how you perceive the world. And in moving forward and thinking about dismantling the institutions that we have and recreating them, one thing we must think about is that all these institutions were built with one type of person in mind. They were built with one type of expectation in how you talk, how you act, how you carry yourself, and what you need. Now that we've become from a monocultural institution that it was built from, and we want to really transcend ourselves to a multicultural institution, we really need to think about what it is and how other people act, and that we need to be the word is not tolerant, but respectful of how others act, how others were brought up, and how others perceive and talk and interact with us.
And not necessarily always thinking that how someone else's act is bad. I feel like that's what happened a lot in the Black community. That's why it's so hard to even talk or be yourself. I feel like it's like when you start talking, everybody be like, oh no, she's saying something bad, or oh no, that's not how you're supposed to do it. Like, who taught us this is the only way we can do anything? Where was it written in the book that this is the way we do it and this is that? That is not the way to live. That's not the way to teach anybody. I feel like cultural differences, we are raised differently, so technically everybody reacts different, everybody speaks different, they act different. And if we all acted the same, we'll all be just one race, and we're not. That's what divides us now.
Yolanda added to this, and I appreciate our 2 panelists are sending me some electronic comments, but she says active listening is so important without judgment, and when we make mistakes, to own them, that it's okay to be transparent and humble. If after listening we say we're going to take action, to take an action to repair a situation, and you must follow through. And then Shiva said that that system of white supremacy to try to push for immediate change and then say, nothing happened, it failed, and so go back to the same practices really holds us back.
So many of these systems and institutions that are in place today were really, as we've mentioned, built on empowering white people. So thinking about that, we think, how does the framework that impacts the ability to serve these communities of color, specifically in regards to healthcare and also other fields, how do we make an impact on that? Cheryl, do you have thoughts on that?
I just want to make sure I understand your question and rephrase it. As a system, how do we make that change and that impact?
Yes.
If you haven't noticed, I like visuals as well as acronyms. And I think I will put here one of the acronyms that has worked, or that we can think about regarding some of the community, working with different members of the community, again, around the COVID vaccine. And I guess one of the main things that as a healthcare organization, also as individuals, recognize that, it's not just going to be us that are going to say, as I said, here's the vaccine overall, but the people who will be listened to are trusted messengers in the community. So in the Black community, it may be pastors or barbers or, people who are trusted, and so we'll work with them overall. So when I say acronym, this is one that that hopefully works and pulls in a lot of what we've already discussed in terms of just what does a partnership look like, because that really is, it's a partnership with community and an organization and institution. It's not an institution saying, okay, we'd like to make change, how will we do this based on the structures that we're used to. So it is CARE, or CARES actually, and the C really starts with credibility and competence. And we're talking specifically healthcare, and so the people who are at the institutions are either experts in healthcare administration, leadership, physicians, nurses, or somebody who has that expertise and competent to be talking about what the issue at hand overall. So I'm not going to necessarily go out and say I'm going to be your financial planner, because you don't want that. But that also brings credibility to the organization. But there's a lot of A's, but I think we have to go back that one has, and this, to really acknowledge the presence of systemic racism and the fact that there is a power structure that is based on white supremacy within healthcare and many organizations. And that's what we're working within. And that racism exists. And that acknowledgement can happen at many levels. And I think about it, you look at the CDC now has pages on racism as a public health crisis and a list of a lot of the work that they're doing to try to really combat that. As pediatricians, our national organization also has race as a healthcare crisis. So that's acknowledging it, but then also acting. And in acting, one also can advocate. So at the individual level or at the institutional level, advocate for policy changes, again with this diversity lens. If we make this change, how will it impact everyone? The R is really reliability. That sort of goes along with credibility, but also, show up. If there's a partnership, if there's a promise, show up. And be there, be available, follow through. And, there might be grants that go out and there's money on board, but it's a partnership. It's not just here, do the money, and we're going to step back, but how can we really still be actively engaged? And E is then also for engagement. That's where community engagement is. And I see that as recognizing that gears mesh. It's really a partnership. That one's not going to be going at a faster speed than the other, but one really needs to work together. And in a lot of those areas, when I talked about building the table, that's important. And then S sort of fits along with sustainability. We really hope that COVID's going to be gone soon, and there's a lot of work built around COVID, or somebody else may have a grant out here around maternal health overall, and that, so when outcomes reach where you want, don't drop the partnership. There's always going to be something else to work on. So, if this partnership can be sustained for a long term, and that those promises are there, and that along the way there's reliability, that those are steps to really build a trustworthy relationship.
I have a question from the audience that was sent here. Someone who works for the local health department and was looking at disparities for vaccination and reached out to specific groups of people, different racial groups, Latino, Native American, and African American, and said, let's try to figure out what are the fears and obstacles and hesitancies. And she says, we were surprised but shouldn't have been, given our terrible racist history with events such as Tuskegee, that some African American residents were concerned that they wouldn't be given the real vaccine, or that they would be given a fake or substandard one. And I think that's a specific example that speaks to a much broader concern about engagement, not only in healthcare, but in many other systems, education, the justice system, where really treatment has been very substandard, and how to address that. And I think, Cheryl, you kind of talked about that a little bit with what you were just saying in your acronym. And I'm curious if you could give an example of some of the work you did kind of related to vaccine hesitancy and the work to address that specifically, as that was the kind of nidus for this question.
So one thing I did mention, and the questioner did mention the Tuskegee experiment, which I guess in healthcare a lot of us hear about. So a lot of the work I was doing, I sort of alluded to a little bit with the COVID vaccine. I'm an infectious disease specialist. I've worked with vaccines, with viruses, so it's, I can sit and I can read, and I can read the papers and understand the safety of it and the effectiveness of the vaccine, and can be very academic about it. But that's not necessarily what is going to combat vaccine hesitancy, and the word, I think we're shifting away from hesitancy towards just lack of confidence in the vaccine and distrust, and the reasons for that. So in talking with people, first of all, I recognize the historical significance of Tuskegee, and just briefly, a lot of people were bringing up Tuskegee as a reason for not to trust medical research. And this was a research experiment that was funded by the public health department, by the government, and lasted for 40 years. And it was a study basically of the natural history of syphilis in black men from 1932 to 1972. And so the researchers did not tell the men that in the 40s penicillin was available for treatment. There were other treatments that were used before, but because they wanted to study the natural history, the men thought they were getting food, they had bad blood, quote unquote bad blood, and they thought they were getting treated or overall, and didn't really know what was going on. And through the study, I think at least 40 women and 19 children were born with syphilis. So it was really egregious, and it led to a lot of practices in healthcare that are now more ethical, recognizing that we need to have more ethical standards. So I often start with just recognizing, and again, that's acknowledging that there's racism and that there's long-term impact, and that this distrust is not going to go away. But it is important, especially in this age of misinformation, to have actual facts and to really know where to go for the facts in order to build confidence in the vaccine. So again, it's not the expectation that people are going to walk out and say, okay, here's my arm, but to just at least know where we are now and why the vaccines will be helpful, especially if you compare to this virus that is so devastating and so deadly. That if you weigh the risks and the benefits of vaccines and the virus itself, the vaccines have much more benefit, and masks do too.
I want to speak on the COVID vaccine in the African American community about not having enough resources or not knowing enough about the vaccination. I was the first of my family to get the COVID vaccine. Everyone else, like I said, In my age group alone, a lot of kids didn't believe, well, a lot of young adults didn't believe that COVID could affect them. They were just going on about their day, saying like, oh, I'm not wearing a mask, I'm gonna still go out and hang out with my friends and party and all this other stuff. But then a lot of people started getting sick. So it was more about, oh, let's protect the older people. The younger people is not getting affected by it as much. But it started to get the younger people as well. We might not have got as sick, but we still had got COVID. And in the black community, like I said, my family alone, just not my family here, but my family out of town as well, they was just like, no, we're reading the news. Everyone's saying don't get the COVID vaccine. There's all these other ingredients in there. Gonna grow a third leg and all this other extra stuff. I ended up getting my vaccine, the first one, and when I got the first one, my whole family was so scared. Oh, your leg is gonna fall off, you're gonna be sick. And I just rolled with the punches. When I got my second COVID vaccine, I was a little sick, but I still muscled through it. My grandmother got her COVID vaccine, and I was so happy because I didn't see her for a whole year. When she got her COVID vaccine, it encouraged everybody else in my family to go get theirs. We were perfectly fine. But like I said, in the media, a lot of the COVID vaccine was a lot like, don't get it, all these other things, or people was getting so sick they were dying, or they had nerve problems. So that's what we seen on TV as African American community. We just knew what we saw, not what we read, not what we were educated about. So that's why I feel like a lot of people in the African American community did not get the COVID vaccine, or was not given a correct place to go get it, or they didn't know as much to get it. They didn't know why it was so important. They didn't know how it can affect older people or younger people or just their family in general.
I was thinking as you were talking, Brianna, we didn't talk about this when we met, but I think that reflects a little bit of kind of who is the system made for too, right? As a white person who grew up in a very, like science-y sort of family, I think culturally this like, give me data and that will help change my mind is the way that I think. And medicine is a very white profession, and I think that's the way we often try to reach people without recognizing that within different cultures there are other ways that you are going to be able to get your message across. And I love what you sharing, like your grandma got vaccinated, right? And then she was like encouraging everyone else to get vaccinated, and that was so much more powerful than stories and data. And I think that there are so many, blind spots within an institution that was made for and by white people around how do we deliver our messages? How, what is the way to speak in a way that's not just a white way of talking, a white way of being, and that really is requiring a shift in what our profession looks like, who is part of our profession, who's setting the table, who's deciding how some of our messages come.
I was thinking the same thing, that stories are so important, and connections. Sometimes when I would just be talking with people asking about the vaccines, there are people saying, I had the vaccine, I've gotten it. And I would come back with the question, how about your family and friends? Do any of them have concerns? What are the concerns? And often there were some, and just helping give words to be able to say, well, this is why it works for me, or why I would like you as your daughter or your mother to get the vaccine. Hopefully it was helpful, I don't know, but just recognizing that some people are going to listen to their grandmother before they listen to me.
I think the speaker this morning said, I wish there are some things about his culture that would become more, or Chinese culture that would become more part of, American culture, including this kind of like respect for elders. And as he was describing that, I just thought that was a beautiful way to think about how if we open our minds and hearts to other ways of being and other ways of thinking, that it's more enriching for everybody, and really how everyone is losing out when we stay stuck in a system that was made for one person.
And that makes me think, when we talk about how can we make an institution trustworthy, it's a daunting task. it seems intimidating at best and just downright scary that how are we going to change a whole institution? But I reflect upon one of my heroes and especially being South Asian, of what Gandhi said, which is be the change that you want to see in the world. And so if you think about that on its surface it seems to be very directed to an individual, that you can be the change that you want to see. But what we forget is that our institutions are made up of individuals. And if we all come together in an institution and want to push for change, we can make change. And that's where I think the strength of advocacy comes in. That everyone feels that advocacy or speaking out or speaking up for someone is a challenging thing. But we do it all the time. We need to continue to do it all the time, and that's really, I think, where when you experience a place that you get the sense that they're thinking about you, that they're thinking about how you think, that makes them more trustworthy. And as an individual on the other side, you must advocate to make sure that the institution you work at, that you exist within, is thinking about that. And small changes add up. So that's one of the pieces I'm hoping that you guys in the audience understand, is that becoming trustworthy starts with yourself, and then your institution will follow in your wake and with your example.
Shiva shared this concept of kind of passing the buck, which I think happens a lot around diversity and equity efforts. That, we have a chief diversity officer. It's their job to work on this, or this person is teaching this session, so this is their problem to fix, and I can kind of let them take care of it. And it is wonderful that we have now Shiva's role in our institution, but she said, I don't have a magic wand, and she doesn't. It has to come from everybody. Yes, there needs to be coordination and investment in it, but every single person needs to be part of that shift and not think this isn't something I have to do. And in my role in education, I lead our social justice curriculum for our residents, and there was, I have sometimes gotten pushback of, you're not a person of color, why are you leading this effort? And it brings me back to a time when I was sitting in a seminar as a learner, and one of my fellow learners, said, well, how do I talk to my family about this? How do I talk to my coworkers about this kind of thing? And the leader, who was a woman of color, said, if you don't know how to talk to your own people, you got to figure that out. That's not my job to tell you how to talk to your people about this. And that really resonated for me, and to me was a call to action of, if I'm just sitting here waiting for someone else to do this work, then I'm part of the problem. And if I'm standing by, that's saying that I think what's happening now is okay. And every person needs to stand up and play their role to be part of that institutional change. We can't just expect the person at the top or the few people in the C-suite to do all the work. It has to come from everybody. We had another chat question here. Thinking about the concept of professionalism that's so entangled with white supremacy, and just kind of curious to hear panelists' perspectives on this concept of professionalism.
So I'll try to address that. So professionalism is an interesting thing. As someone of South Asian descent, I was always told that I needed to, by my father, I needed to act professionally, that I needed to act correctly. And it was never defined to me what that correctness was. I always had to kind of try to find my way through of what was correct and what was incorrect. And the way that you find it out is you see the reactions on people's faces when you say or do something that is not considered to be correct. And I slogged my way through my career trying to be correct, trying not to speak out, trying to fit into a mold that never really existed. And so I think when you think about professionalism, the way I think about it now is I want someone to act in a way that respects me, that provides, that imparts a sense of humility, and imparts and demonstrates the willingness to listen. Those are the key factors I see as defining somebody being professional. It's not in how you look, it's not in how you dress, it's not in what you say or how you say it, but it's really those key parts of it: humility, respect, and listening. And I think that if we move forward with that in the front of your mind in any interaction that you have, that will diffuse any conflict or situation very easily, and two, will make it so that the person that you're interacting with feels that you are trustworthy.
I personally never understood the word professionalism. Like, I never understood it. It was like, it's a straight line. You can't go out the line. There's no gray areas. It's a straight line. I never understood that. Because the way you speak and the way you act, how is it unprofessional? Because it's not the way that you speak and you act. Now, I can understand, like, not using any horrible words or, like, not talking to somebody, talking down on someone. But as far as being black, I feel like it's aggressiveness that when I speak or my voice carries too hard is not professional. How is that? That's how I was raised. This is my voice. I can't change it. I'm not willing to change my whole life just to be fit into the straight line of being professional. I never understood that. As far as I want to talk about privilege. Now, this goes a long way in healthcare. We talk about this all the time. I'm not just saying white privilege, but just privilege in general. A lot of people talk about how, when you're white, you get more privilege, or when you act a certain way, you color in the lines and you don't go out, you get more privilege. More people respect you. More people want to listen to you. You're better than the next person. And I feel like that is so wrong in healthcare. If I act a certain way and someone else acts a certain way, how is that better than what I'm acting?
So as we move forward, I'll ask, so the accountability is really the key thing. How do we, in a healthcare system or in any system, really push for that accountability? Emily, do you have thoughts?
I think when you say you're going to do, Yolanda contributed this before. If you say you're going to do something, you do it. You follow through. And often that action comes after listening. I think that part of being accountable is creating that time and space to listen, not just once, but in an ongoing way, and that we can't be accountable as an organization or a system if we don't have continuous listening and an effort towards continuous change and evolution that I think has been missing in healthcare in many institutions for a long time. I'm thinking about my role in education, and a question came through about recruitment too, and diversifying the workforce, sort of a thing. I think once you have a role and you find yourself in a position of power or at the table to make decisions, keeping this at the front, not letting it be something that kind of slides to the bottom, and depending on your role and your position in power and your own identity, that can include making sure it's on the agenda, amplifying voices of others who aren't at the table or who historically have not had a chance to be at the table, or who maybe are sitting there but not actually given power, and kind of calling that out when you see it. Those are some things that come to mind to me. It looks like maybe Cheryl has more to add to that.
Well, I agree with all of that, and also in the structures that we work with, There's a lot of policy making, a lot of writing it down, and I think that is important. You know, after all the steps that Dr. Riedinger put out, that, you know, if as a group one says, this is our mission, this is our vision, and this is how we're going to fit into it, that can be written down, so that if somebody new is coming into the organization, they know that this is part of the mission and the vision. Early on, about 2 or 3 years ago, when we were starting some of our strategic planning in our department, I had reason to be looking at different departments across the country at different websites. And there were a couple of institutions who right on their front page talked about their efforts in diversity, inclusion, and equity, but then also spelled out this is how we're going to do it. So having something forward facing that says this is what we want to do and this is how we're accountable. And again, as I mentioned before, like the CDC has their web page, and this is a list of what they're going to do.
Something that UW Health has done that I thought was powerful within the last year and a half or so, you know, thinking about policy is they came out with a policy on microaggressions, and kind of very clearly said and stated and disseminated that, you know, providers are not expected to tolerate experiencing microaggressions perpetrated by their patients. And I think in an industry like many others where there's a little bit of a kind of the customer is always right, there was a sense sometimes among providers who are underrepresented in medicine that, you know, if I have a patient who's being racist towards me or something, I just need to tolerate it and take care of them. And UW Health coming out and saying, no, actually you don't, and here's what we're going to do to support you if that happens. So putting stuff down on paper like that, I think, is important. And obviously that's not, just saying that isn't going to create the change. You have to shift, you know, people's culture. You have to empower people to intervene as bystanders and that sort of thing. So it's not like the world changes when a policy like that comes out on paper. But I think some of those things are hard to write down, or important to write down, excuse me, so that we know what does our institution value and how are we going to kind of put our money where our mouth is, so to speak.
And along those lines, you know, we say we know, but as somebody who's coming in from the outside, how do you know what that institution you're interacting with values? You may read it on their website, you may hear it in their mission statement, but what is actually happening? Is it better to know what the institution's expectations of their own employees are, what their institutions, how they treat each other is? That level of transparency is key to becoming trustworthy. When we hide behind the walls, when we hide behind our desks, when we hide away of what's happening inside so that no one can see what we do, but most importantly, no one can see when we stumble, when we fall. It's not a question of if you're going to stumble or fall. It's a question of what do you do to pick yourself up? And knowing what a group or what a person or what an institution does when it does stumble and acknowledge it's stumbling and pick itself up, will really, if you think about it, would you rather know what they did wrong and how they rectified it? Or would you not rather, or if you hear that they haven't done anything wrong at all, which do you think is going to be more inviting to you to interact with and to you to open up about?
Brianna, there was a question about diversifying a profession and you know, thinking about prioritizing funding to bring people into a field such as medicine, but many other fields, you know, too. And I know you had some experience as part of your MA training in a cohort, and I'd be curious to kind of hear more about that, or how you see that kind of playing into that concept of creating a workforce that better reflects the patients or the community that we serve.
As far as diversity in our workplace, when I was in because I took the MA program through the UW hospital, there was only 3 black people in the program. When I graduated, I went to I externshiped at 2 different places. Both places I was the only black person at. A lot of patients will come in and they'll say, oh, you're the only black person. I've never seen a black person work here. And it was white, black, it didn't matter. You know, they always ask like, oh, when did you start working here? Or when did you graduate the program and start working? And I used to always tell them, the question never bothered me. It was just working in a place where my face is the only face I see. It never bothered me. It's just better help me educate all my coworkers. Even like my docs, I love working at my clinic. I love all my providers. They are so understanding. They work in communities. I'm pretty sure they work through workplaces where it's not as diverse. They have a lot of patients. They have black, white, all races. So it's easier for them to understand when I speak. It's easier for me to talk to my coworkers. It's easier for when, like I said, when I'm working at a place, when I'm the only person there, it's probably a little harder for me to talk and people to understand what I'm saying, but it's easy for them to catch on. It's easy for me to explain to them. They're so willing to learn. So I think that's the biggest part for me, is people to understand and learn different cultures. That's like the biggest thing for me. As long as you're willing to learn and you're willing to understand that everybody is not the same. And me too, it was a lot for me to learn. Like I said, I worked for the university for a long time, UW Hospital. And I've been in a lot of different departments. And it is easy for me to adapt. It's easy for me to learn new things. And I feel like with that, it's easy for me to open up. I feel like I spoke to a lot of people, I've met a lot of people that have taught me a lot of different things that I didn't know myself. So if I can learn, I feel like everybody can learn how to open up and think that different cultures do things differently.
I was going to explain just a little bit of some of the experiences that are going on at UW Health, or initiatives, I should say. And the question was about, I guess, diversifying the workforce. And, you know, there's a recognition, and we all know that there's talent throughout this country. And a part of recruiting has to do with not just getting numbers up or having tokens overall, but having a space where people who are historically underrepresented feel safe and welcome. And so there's a couple of programs that I can think of right now, and sort of like with the medical school, you know, we have diversity officers, we have mentors. I'm one of the mentors overall, so that students know that they have somebody to touch base with about how to advance in careers overall, or even just call up and say, hey, this is going on. We've been involved in the Department of Pediatrics of getting many of the residents and faculty together of color, just saying we recognize that we need safe spaces, or spaces where we can just go, phew, because working in predominantly white institutions is sort of constantly being on in a culture that's not necessarily your own. So being able to have those opportunities as students, as learners, as faculty, to not have to be concerned about that all the time, and also know that you can just continue to advance and have the support around you is also important. So it's not just the numbers. It's how, as an institution, does one really encourage support, belonging, welcoming.
Shiva made a comment about accountability, and she wrote, to be accountable, we need to step outside our four walls and actually be willing to listen, but also take action on hard truths we hear from our community. I think that was, probably more of a comment than a question, but I'm wondering if anyone wants to build on that concept of hard truths and taking action.
I like the saying that I used to always say, because a lot of people say things that they don't feel is necessarily racist, and I always tell people, if it will hurt if someone said it to you, then don't say it to someone else. And a lot of people be like, wait, well, how do I know if it hurt? If you said something and if someone said that to you and you would get offended, don't say it to someone else. And they'd be like, okay, that makes sense. And I'm like, that'll leave a lot of people unheard or don't know what to say after a conversation is ended.
And, there's the saying, speak truth to power. And although that sounds great, it's hard to do. When you're in a situation when there's a power differential, how do you speak the truth to that power? How do you speak that truth to that power when your employment, your livelihood, everything hangs in the balance because of what you see and what you do? And this is where I think institutions that have ways of allowing people within their institution and people outside to make comments, to speak that truth in a safe space is really important. And at UW Health we do that. We're trying to do that. You can make comments, you can speak, and then what is being said is not considered as truly as being antagonistic or attacking, but more for education and improvement. And I think that, again, that comes to the thought that humility that you bring when you're listening is very important.
I think that humility is so important there, and it is really hard to speak up to your physician or your healthcare team, right? If you are sick or your child or parent is sick, it's such a vulnerable position. To give feedback that you're not sure how it's going to be received is an incredibly difficult thing to do, and I think that's true in many industries, right? As a parent, I think about, I don't want to make my kids, teacher angry or, that sort of thing, and so, demonstrating that willingness to listen and take feedback and take it in and sit with it for a while is so important, because it is such a difficult thing to do for someone in that position of vulnerability to step up and say something. And it also makes me think, when that moment does happen, how many missed opportunities have there been? How many times has something happened that people haven't said something about? And so recognize that when one does get that feedback, when someone is courageous enough to stand up and do that, to realize that this is probably not just a one-off, but this is the time that I heard about it.
So we're running out of time, it seems like. So at this point, I'd like to ask everyone on the panel to just leave you with some final thoughts on this topic and what we're thinking about. Rianne, would you lead us off?
My thoughts about healthcare and the trust and trustworthy: just be open, be honest, speak your truth, be okay with not knowing that, or be okay with not seeing that everyone will see the same thing you see, but it's okay to educate them.
I think I'll follow that with that: have the humility to know that you're going to make a mistake, and be open to hearing about it when you make a mistake. And that when someone tells you that you've made a mistake, what you need to know is you need to know what you're going to learn from it. I have a T-shirt that drives my son crazy, but it says, I've learned so much from all my mistakes that I continue to make more. And that's what we learn from, is what we don't do. I was at a session where we were talking about racism and equality, and one of the things that came up before the session started was that there was a feeling that everyone must commit to not offend others. And I had to raise and say, how do you expect to be truthful? Because I know that my truth may offend somebody else. But if I do offend you, let me know about it. Let me learn from it. And I think that that's where we and our institutions really must strive for, is to have the humility to make errors and then learn from those errors.
I have to echo the sentiments about humility and active listening overall, but just really recognizing, as I look around, what we see as physical characteristics don't necessarily represent who we are and where we've come from in terms of individuals. We all have a history, all have a background that are going to dictate how we interpret a situation. So, listening carefully to recognize what somebody's perspective, acknowledging that their lived experience really is their lived experience, and recognize who they are, believe that this is what they're saying, and then partner and work from that perspective, being humble about it.
I will agree with what all of my wonderful colleagues have said, and I think kind of in addition, just leave you with this, if you want your institution to change, if you want your system to change, don't wait for someone else. That you're part of it too, and that you have a responsibility to be part of that change. Otherwise, you're saying what's happening now is okay, and to step up and do that. I have a comment from Yolanda, which I think was probably not meant to be her summarizing comment, but she said, someone in the chat talked about the power of language and being inclusive in language and modeling that. And she said such a good call out for an opportunity to be more inclusive in language that goes unnoticed if we don't stop to pause and listen to feedback. So sometimes it's those small things. Language is powerful. All these little things can really make a big difference. And continue to say that intersectionality is complex and so intertwined with systems of oppression, that having that awareness of that concept too.
Thank you all very much.
I perhaps, unlike some of you, have had the opportunity to go by several of the panels and can say that if you have taken from them like I have, then we have some valuable tools that we can take in our respective spaces to help move the agenda forward, right? To progress the sense of belonging amongst folks who perhaps do not look like ourselves, to engender equitable and inclusive working and learning environments. And so I'm so grateful that you all chose to spend time with us today to impart your words of wisdom and give us your experiences. So thank you.